Welcome everyone. I am Dr. Nalini Kaushik, and today, as we observe World Kidney Day, we are joined by some very eminent experts from our country to discuss kidney cancer progress and challenges. So I'll just begin with introduce us, our panelists here, and then we would be joined by our moderator who will take the discussion forward. So we have here with us Dr. Makaran Kochikar. He is the chairman of Department of Uro-Oncology at Siddhi Vinayak Ganpati Cancer Hospital, and he's currently the president of Urological Society of India in the West Zone. Professor Dr. Raj Nagarkar, MD and Chief of Surgical Oncology and Robotic Services at HCG Manvita Cancer Center. Dr. Prashant Nayak, he's the additional professor and head of Department of Urology at AIIMS Bhubaneswar. And we will shortly, in some time, will also be joined by Dr. Anita Ramesh. She is a consultant medical oncology at Apollo Specialty Hospital. So at the outset, I would just like to say that thank you to all of you. I know, despite your busy schedules, you have spared, some valuable time to be here with us and to be part of this conversation, which I'm sure is going to benefit the audience at large to understand more about kidney cancer. So without taking a lot of time, I would like to invite our expert moderator, Dr. Kochikar, to lead us into today's panel discussion. And big thank you to sir for being here with us and helping us moderate today's conversation. Thank you so much. Over to you, sir.
Thank you, Dr. Nalini. At the outset, it's a great pleasure to be part of this symposium or interaction. When Dr. Nalini contacted me for the first time, I just didn't know the organization and how things are and what is expected. And as she made it very clear, this is basically for common man or sort of in a community. They need to know on the World Kidney Day. So I said, okay, we will just go ahead and do it. And thank you for organizing such a wonderful panel. Dr. Nagarkar, Dr. Prashant Nayak, who's a urologist at Bhubaneswar, and I'm sure Dr. Anita will join. Dr. Anita is already here. So we will just take you all through, what the kidney cancer is and how do we approach and what things are going to be seen in the future. Are we ready with the slides?
Yes.
Okay. So next one. Greetings from my hospital, the next one. This is Siddhi Vinayak Ganpati Cancer Hospital, Mirrors. We started Uro-Oncology department about 25 years ago. Next one. And this is another new hospital which I built just recently, about 350-bedded multi-speciality hospital, where we are doing this sort of, urological and urological cancer work in both these hospitals. Next one. And I already told you the panelists what we have, and it's a pleasure to have all these sort of expertise who are going to interact with us on kidney cancer. Next one. Kidney cancer in general, there are two things in people in community always get worried about. Anything to do with the kidneys, people are really scared. And on top of that, when you say the kidney has a cancer, then people get still more worried about it. Next. Just to summarize, we have sort of a kidney here. People have two kidneys, right and left, and there's a ureter which drains the urine, and that's the bladder and the rest of the lower urinary tract. The next one. Now, as you see the red dot here into the right kidney. When there is a lesion here, that's called as a kidney cancer. The next one. Now we are going to take to our panelists, and they're going to explain to you, what the common symptoms of kidney cancer. Now, Dr. Nayak, can I pick up your brains and can you just explain to the community, how did this sort of kidney cancer presents and what are the symptoms of these patients who harbor kidney cancer? Dr. Nayak.
So at the outset, I'd like to thank for this opportunity. Kidney cancer is an imported cancer. We see a large number of patients. The symptom-wise, most of the patients are asymptomatic. In the present era, most of the patients get an ultrasound done for something else and then they get picked up with a kidney cancer. But kidney cancer does manifest if cancer grows to a large size, then it can cause local pain. Some people can feel a lump. And sometimes if the cancer erodes into the kidney where the urine is formed or urine comes out, then it may cause hematuria or blood in the urine. So these are the late symptoms. So once the kidney cancer grows, becomes a large cancer, then you can have pain, you could have a lump in the abdomen, and you could have blood in the urine. But as I said, most commonly it is currently detected as an incidental finding. Get an ultrasound or something else, and then you come out and then you find that there is a mass in the kidney.
Yeah, absolutely right. Can we go on our next slide? As Dr. Prashant has mentioned here, patients do have when they have a lump in the abdomen. Previously, we used to call this a classical trial. Patient have a pain in the abdomen, they have blood in the urine, you could feel a lump in the abdomen, but the days are gone now. As now people are asymptomatic, they don't have any symptoms. And incidentally, when you do a health checkup or ultrasound, you can get a cancer detected on sonography or a CT scan. Next slide, please. And this is how typically it looks like a kidney cancer on the right side as such. Next one. Now, if you look at the sonography, sonography is a common tool or common investigation done by many people. And what tells us whether the patient has a kidney cancer, the sonologist will tell you there is a suspicious growth in the kidney on a sonography. Next one. Dr. Anita, if I ask you, I'm sure as a medical oncologist, you will see people with the stage 4 disease, and then we'll have also a discussion during MDT. So once somebody approaches you with a tumor in the kidney, then what happens? What do you do next?
I think this would have been a better question for the surgeons. Okay, yes. But still I'll try to answer. Yeah, I think many of my colleagues, doctor, will also agree. This is a surgical question, preferably. Yes. Yeah, so we do get cases when they with a sonography with a kidney mass. First thing we discuss APS in a multidisciplinary, and I would like to bring my surgeon into the picture, which is definitely a urologist or preferably a neuro-oncologist. Because there are several things involved in it. We need to do the imaging of the kidney to see how far it has spread, there are many types of kidney mass. It depends upon the age, it depends. Children have Blind's tumor, adults have renal cell carcinoma, they have transitional carcinoma of the renal pelvis. So everything is a wide variety of things. Usually for kidney masses, we don't do a true cut biopsy until and unless the stage it is 4, where everything is met, and then you get a biopsy from the metastatic side. Preferably to bring the surgeon in, plan for a CT scan or a PET scan also we do with the contrast to see how far it has spread. Renal vessel, renal vein involved, the fascia of the aorta is involved, nodes involved, supradiabetic, infradiabetic spread. We look for thrombus. Okay, so all these parameters, and we want them to do the surgery if possible at the earliest. Yeah, I think the surgeon can continue after me. This is a surgical question. Yeah.
No, I mean, I just trying to get you involved right from the beginning, because what we will have sort of discussion on a stage 4 will be at the last of discussion. So I just wanted to get you on the board when started the discussion.
Thank you so much.
As Dr. Anita mentioned, we do the next investigation, a CT scan. Next slide, please. So as she has rightly pointed out, we want to know the extent of the tumor, how the tumor has spread, whether there is a clot in the blood vessels, what we call as a staging of the disease, whether the disease has spread anywhere. So what we require is basically do a CT scan. And I think you should have a best of the CT scan, because if you have a poor quality, which does not tell you the veins and arteries and sort of systemic spread, that CT scan has no meaning. The next slide, please. This is typically a kidney cancer seen on the left-hand side with sort of tumor thrombus going into the main renal vein. And as a surgeon, we need a roadmap, and that's why we need a proper CT scan. Next one. This is another patient who just had a trauma and then subsequently found a blood in the kidney, but a tumor. The next one. You do have fancy pictures, you do have 3D pictures, and that would also tell you what's the blood supply like, whether it is involving the adjacent organs. The next picture, please. Next slide. And these are the 3D pictures. Next picture. Next slide. Next. Next. What is important in all these? We need to know the blood supply of the kidneys, and that is what is extremely important. Now, what is important here is this patient has tumor in both the kidneys, as his luck would be. So if you want to save the kidneys, we're going to take that discussion in due course of time. Along with the CT scan, what I ask for is basically a renal angiography. And most of the latest CT scan equipment, they do have this sort of technology. So patient undergoes a CT scan. It's not only the morphology what we're looking at, but we want to know what's his blood supply like, what's the tumor's blood supply like, whether we can sort of conserve the kidney. And it's extremely, extremely important to have this kind of picture. Next slide. And similarly, this patient has only one kidney, has a tumor there in the low pole, and I want to save the kidney, and that's why I need to have an entire picture. Next slide. Now, many people come here, and they say, doctor, you've done an ultrasound, I've done a CT scan, now I want a PET scan now. Now, Dr. Prashant, do you think PET scan is really indicated in carcinoma?
As such, the FDG PET scan is not indicated in the primary assessment of a kidney cancer. Right. So there is a role of the PSMA PET scan is coming up, but an FDG PET scan is frankly not indicated in assessment of the primary tumor in a kidney cancer.
Can we go on the next slide? Now here I make it very clear, because as a community, people here, there are a lot of, I understand the audience is a lot of people who are non-related to medical field. So before you ask for an investigation, so-called fancy investigations, it's not a fancy, it's important investigation. But as far as kidney cancer is concerned, it doesn't have a role in the routine sort of a use as such. Sorry. Maybe once the patient is treated with stage 4 disease, requires any further monitoring or want to know the metastasis, maybe it's useful. And we do an MRI when the patient's kidney function is not pretty good. A lady who's pregnant has a kidney tumor, we do that. We don't know whether it's sort of in a malignancy or not, or whether they've done surgery, want to do a follow-up. I think MRI is also possible. And many times when you do nephron sparing surgery, we use an ultrasound during the surgery. Next slide, please. Now coming to the important entity, which is small renal mass. The small renal mass is an entity, as Dr. Prashant has mentioned. Now we see more and more of those. When I started my work almost 30 years ago, we were seeing large, big tumors with the bilateral kidneys, IVC thrombus, metastasis. But what now we see is a small renal mass. Next slide, please. When do we call this mass as a small renal mass? Is when the mass is less than 4 centimeter, and we call it as a CTA, or clinically, it is the T1 disease. Next slide, please. So why do we want to know about this small renal mass? More than 20% of they are benign. So if you see just a mass, you really don't want to jump and operate on those. There is usually a low chance of progression. There is a lot of work going on, and I'm happy to tell you that we were involved in sort of growth kinetic study of the kidney cancer. It has a very low chance of metastasis, and even if it is a malignant, almost less than 20% are of high grade. So we really need to think and approach them differently, rather than saying, okay, this is a mass, I'll take it out, because there are different ways of skinning a cat. And if you know that this is a small renal mass, we can have some alternative options. Next slide, please. And this is a gentleman from Canada called as Mike Jewett, who has spent his lifetime work on 2 cancers, kidney cancers and testicular cancer. And a lot of work has been done along with him about the small renal masses. Next one. Now, evaluation of small renal mass. Usually, next slide, please. As I told you, the natural history of the kinetics, next slide, is usually grows by 0.2 centimeter per year. Next slide. And as Dr. Anita has mentioned, usually we do not need to biopsy, because most of the kidney masses are usually diagnosed very typically seen on a CT scan. Very rarely you need to do biopsy. Next slide, please. Now, as I said to you, almost always diagnostic, but if you have an old man, you want to sort of preserve the kidney, you want to do active surveillance, then probably you need to do biopsy. Next slide, please. And I just want to tell you that we also do a biopsy in certain situations when the patients have certain odd lesion, which is not sort of very classical of kidney cancer. Next one. This is why you need to avoid, with the biopsy, patients can get hematoma. The next slide, please. Then this patient would have had a nephron sparing surgery, meaning we would have had a sort of partial nephrectomy, but a badly done biopsy, the patient has blood everywhere, and you don't know what the margins are like, and sometimes you may have to sacrifice the kidney, is extremely important. The next slide, please. So this is a tall mineral mass. We haven't removed the kidney. Just with a safe margin, we actually do a nephron sparing surgery. The next slide, please. To summarize, when we see a small renal mass, 20% will be benign. It can be safely observed, is called as an active surveillance. If it is showing indolent cancer, means cancer is very of a low grade, patients is elderly, patients have bilateral lesions, then you can always do a thermal ablation and a partial nephrectomy. And if it is an aggressive disease, which is more than 20% chance, then usually we go for a radical nephrectomy. Next one. Now that kidney cancer is suspected on imaging, what next? Next slide. So if it is a mass which is more than 4 centimeter, usually we do something called as a radical nephrectomy. What it means, you remove the entire kidney, the adrenal gland, the lymph nodes all around, and this is a radical operation for a bigger renal masses. If the mass is small, less than 4 centimeter, we do something called as a nephron sparing surgery or a partial nephrectomy. Next slide, please. This is a radical nephrectomy. This is a nephron sparing surgery. So I'm sure you understand kidney along with all its sort of covering gerotus fascia and upper ureter and adrenal is all taken out. In a partial nephrectomy, along with the safe margin, only a portion of the kidney has been taken out. Next one. This is how the radical nephrectomy, the whole kidney can be taken out. The next slide. You see the whole kidney will be taken out in radical nephrectomy. In a partial, only a small portion is taken out. Next slide, please. Now, as Dr. Nagarkar has joined us now. Hello, Dr. Nagarkar.
Hello, good evening.
Good evening. I know the work you have been doing, an excellent robotic work also you have been doing. We are now on the stage where we're discussing the nephron sparing surgery. And I'm sure the robot and laparoscopy has come in a big way in doing nephron sparing surgery. Here I've just put some steps how we do nephron sparing surgery in an open way. What's your view on sort of doing nephron sparing surgery in a laparoscopy and robotic way?
See, definitely, I think we've already summed it up because nephron sparing surgery, both like we do come across being a tertiary cancer center, maybe a young patient who has got incidentally screening detected cancer only at either pole, upper lower pole, or even in the mid part, but more on the outer cortex type of lesions and with minimal nodes. So these are patients where rather than sacrificing the entire kidney, one should make every possible attempt to save the kidney. At the same time, there are patients who have 2 lesions on either kidney, one on either kidney. So in terms of like if you have to sacrifice one kidney and the other kidney where you can try and save as much as the kidney is possible without compromising on the oncological principles. It is extremely important in nephron sparing surgery or when we plan that trying to preserve the kidney but keeping some amount of tumor tissue behind is an entirely waste. It's a futile effort. And we need to make sure that all the hilar nodal clearance also has to be done. It is not an incomplete job. It is a complete job preserving the kidney. So in that aspect, cooling of the kidney is a preferred part. You should have a good vascular control. In fact, since I have evolved over all 3 aspects of surgical oncology training and techniques, where it is the open surgery or the laparoscopic and the robotic surgery, since we are discussing on a forum where many of them are non-medicos or there's for a common man point of view, I would like to, for the benefit of everyone, like many a times people have this notion or misconception that when you do a laparoscopic surgery or a robotic surgery, are we doing a suboptimal job? Do we tend to see less or we cannot feel the tumor, or are we removing the tumor in a piecemeal manner? Fact is that in laparoscopic surgery or robotic surgery, you can actually see the things much better and you cause minimal damage to the surrounding tissues. So it's like in robotic surgery, you have an additional advantage of a 3-dimensional vision and a magnified image. Though now there are 3-dimensional laparoscopes also available, but a 3D image with a magnification and having the camera under your control. An additional advantage of robotic surgery as compared to open or laparoscopic surgery is that the energy devices, nowadays we don't do these surgeries using the scissor or a knife. All these surgery are done by electrocautery equipments, and as compared to open or laparoscopic surgery, the electrocautery energy setting in robotic surgery is almost 50% less. So you cause less thermal damage to the normal tissues and recovery is very fast. In fact, majority of my robotic nephrectomy patients get discharged within 48 hours. And in case of female patients, if we have to do, like day before I did one where the lady needed a hysterectomy also in the same setting. So we do a nephrectomy, do a panhysterectomy and deliver the kidney from the vagina safely without compromising. So it becomes a natural orifice surgery and the patient can walk out very comfortably from the hospital within 48 hours without much pain. There is no bleeding, there is no risk of infection and all. The last part which you have highlighted is about the frozen section and the intraoperative ultrasound. In case of nephron sparing surgery, it is extremely important to have you should not miss out any small lesion in the kidney. So intraoperative ultrasound should be done. The robot which I am using, the CMR robot, does not have the ability to have it does not have an inbuilt intraoperative ultrasonography. And second part is even these newer techniques like ICG. Using ICG helps better delineation of the vascular supply of the kidney, and that can also help to take the vascular control better. And you do not cause ischemia or damage to the normal healthy tissue kidney which you want to save. Frozen section biopsy is a technique where after the surgery, when the affected part is removed, we send it for histopathology where the report is available in 15 minutes, unlike the normal 4 or 5 days delay. So in 15 minutes, we can make out if the tumor has been removed adequately or we need to revise some part of the margin of the kidney.
I think you have elaborated it very well. And two important things you have made it. I think it should be done in a tertiary cancer center where people have expertise in doing this procedure, because this has a really Six Sigma kind of sort of an expertise. You don't have a second chance because, the kidney, if you leave a small putty kidney, then it has no meaning of doing nephron sparing surgery. So you need the expertise. The next slide, please. And here I'm showing you sort of what it means like, this patient had a tumor in the lower pole of the right kidney. The next slide. And this is done in open technique. This is done many years ago. What we do is, this is the kidney here. We have put a clamp across. We put the kidney into ice slush. Next slide, please. And then we remove this sort of a tumor with a good margins. Next slide. This is the tumor with a good margin and a base. You will see that does not have any tumor. Next slide, please. And many times, if you don't have a frozen section, once you cut open the specimen, you have taken an adequate margin. But usually as a practice, till we suture the kidney, we send it for a frozen section, get a proper answer for that. The next slide, please. The amount of time you have in your hand when you do this nephron sparing surgery is debatable. When you do this surgery, and if you have clamped the vessels, ideally you should do it within less than 20 minutes, especially there is no ice slush around. But if you're cooling the kidney with ice slush, which is possible only by open surgery and not by minimally invasive surgery, and we still try and do these kind of procedures where a complex tumor, the larger tumors, the solitary kidneys, then you can take your own time, almost like 35, 40 minutes, by putting the kidney into ice slush and do a proper job, because you want to do an oncological clear job, as well as we do not want a recurrence, and we want to have preservation of the kidney. The next slide, please. Now, this patient underwent surgery, and then you see what has happened after 3 years. The next slide. Next slide. You see this is an IVU, CT IVU, and you see the entire renal function on both sides is very well maintained. The next slide. Beautifully maintained renal function without any problem. The next slide. And this patient, I told you when we started our discussion, patient had a bilateral tumors. The next slide. This is almost 20 years after saving the kidneys on both sides. One patient had a partial on the left-hand side and the sort of partial on the right side. 20 years down the line, no recurrence. So this is new advances and development in a management of kidney cancer. The next one. This is 16 years after, another case, 16 years after, no recurrence. You see the part of the left kidney has been taken out. His creatinine is very well maintained. Next slide, please. As against to that, when I talk to you about, next slide. Next slide. This patient had a large tumor. Even if you want to, you can't really do a partial nephrectomy. The next one. And the proof of the pudding is the same patient you see, it looks like an exophytic tumor, but a lot of tumor is within the kidney itself. So yes, you have a technology, you have minimal invasive sort of surgery, robotic, laparoscopy, but as a surgeon, you should know when to operate, when not to operate, especially the nephron sparing surgery. The next slide, please. Now, next slide, please. Now this patient looks like, you can do a nephron sparing surgery. The next slide. This is typically sitting in the middle portion of the kidney. Next slide. I'm glad I did not do a nephron sparing surgery because, it is all invading the, the inner structures of the kidney. You won't get sort of adequate margins, and you can't leave a small tissue on the top and small tissue on the lower, just saying that you have done nephron sparing surgery, which has no meaning at all. Next slide, please. And as Dr. Nagarkar, as well as Dr. Prashant would agree with me that you need to do a lymph node dissection in a clearer manner. Next slide, please. Next slide, please. This is how we should do it. Now, Dr. Prashant, I'm just going to ask you about these complex cases. Being in Bhubaneswar, being in a tertiary center there, you do get these kind of patients.
Yes.
So just I'm going to explain to you the next slide, please. What it means is this is a typical patient. Patient has sort of a kidney tumor and it has a clot, which is clot not just of a blood, but it is the cancer which is going into the big vein which drains the kidney and going to the vena cava. So this is called as a thrombus. Next slide, please. Could you tell the audience, Prashant, how do you approach these people and what's the outcome these people have?
Okay, so these patients, these are complex cases where the tumor is extending. There's an extension of tumor into the renal vein or the veins of the kidney. Also, that extends into the inferior vena cava, the large vein, the central vein in our body where all the blood returns. So this is a difficult case to manage. So if, as long as it is confined to the renal vein, to the veins of the kidney, we still can manage it laparoscopically. We have done it with laparoscopy, or we can use open surgery. But the essence is we need to get the kidney and the thrombus and the clot in its entirety. If it extends into the IVC, then also laparoscopic option is available as long as the proximal extent or the extent away from the kidney is not too far. If it goes too far, like you can see in the picture, there are 3 veins that are joining the IVC. Those are the hepatic veins. So for me, that forms the cutoff. If the tumor goes at the level of hepatic vein or above, then I get the support of my cardiothoracic surgeons. They come in, they put the patient on a cardiopulmonary bypass. So we entirely bypass the blood from the system. So we have a bloodless field. We control the adjoining vessels, open it up, and then remove it. So this is for these tumor clots that reach the hepatic veins or above. Sometimes we have seen tumors reaching the heart itself. This tumor clot can go up and reach the heart itself. So in those kind of patients, we need the cardiothoracic or the heart surgeons to come in and play their part in diverting blood away from the system so that we can open it nicely and remove the tumor with the clot in its entirety. If it is below the hepatic veins, we could manage it with laparoscopy or by open technique. But as I said, the essence is that we remove the tumor and its clot in its entirety.
Perfect. I think this is what it is, because many times when you get this sort of, next slide, please. Many times when you get these references saying that this patient has sort of a thrombus. Next slide, please. What we do is, as Prashant has mentioned, and I'm sure my colleague Dr. Nagarkar would also agree, we need to have a control on the big blood vessel which goes to the heart. It can be done laparoscopically, it can be done sort of open or robotic. Next slide, please. And the outcome is not bad. The next slide, please. So this is the same case what I showed you. This patient had this one, and then we cross-clamped the vena cava. The next slide, please. And you see this is a tumor, part of a vena cava and a tumor thrombus, which is all come out. There are high lymph nodes here. The whole kidney has come out. The next slide, please. Tumor thrombus. The next slide, please. And what we do is we repair this vena cava. And you require a training in the vascular surgery. Being also exposed to transplant, we do it in day out. Next one. And this is how the vena cava is completely repaired. So whenever we get even these kind of tumors, we usually take surgical exercise. They don't do as well as stage 1 and 2 disease, but certainly the outcome is not so bad in these kind of patients. Now, next slide, please. Now, what about this cyst? Many times we get this sort of lesions called a cyst. And this is important. I brought it here for the community because a lot of people come to me and saying that, doctor, I've done an ultrasound. We found a cyst in our kidney. Is it cancerous? Next slide, please. This was a radiologist, who was called as Bosniak after his name. Next slide, please. We do sort of assess on a CT scan what kind of cyst it is. What cyst means? It is not a solid growth. It is just sort of cyst which has a fluid inside. The next slide, please. And when we are concerned about majority of them, 1 and 2 types, usually do not require anything. So even if people scare you and say you that you have something like growth on the kidney, if it's a cyst, believe me, you don't need anything to be done. But if it has a solid component and your doctor would tell you which has a solid component, then perhaps we can save the kidney. The next one. Now, do these patients need, I'm not talking about cyst, Dr. Anita. Now we are going to talk about the stage 4 disease. Now, these patients, before we talk about stage 4 disease, patients who have stage 1 disease where we have done a partial or radical nephrectomy, stage 2 radical nephrectomy, stage 3 with renal vein and IVC thrombus, could you tell the community that do they require additional therapy like chemotherapy, immunotherapy, radiotherapy after surgery, like any other cancer? Dr. Anita.
Yes, please, sir. Just I would like to make one comment. Excellent slides. I enjoyed those pictures. It was too good. Okay. Thank you so much for lovely slides. Hardly I can make them. Okay, let's come off to the stage 3 disease. Okay, yes, stage 3 definitely it's a extranodal, it's a nodal, extranodal, larger mass which is getting into the outside. This thing will need the local radiation at the primary site, enclosing the entire tumor bed, maybe the nodes also if there is positive. That goes definitely. Regarding, there is no role of chemotherapy as when you are just speaking of renal cell carcinoma. There is tyrosine kinase inhibitors are present. Definitely stage 3, we do a risk stratification. Okay, and with the risk stratification, depending upon the size of the tumor, extranodal spread, number of nodes, definitely this will need adjuvant. Sotatercept is the drug of choice, still holds good. It's 6 months, it's known as TKI. We don't tell chemo, tyrosine kinase inhibitors perorally to be taken for the 6 months, and then we repeat the scan, and along with that, the radiation is completed. That's all is about the adjuvant therapy. Beyond this, few drugs have been tried, but still not yet approved. Immunotherapy, nothing. That as on today's stage 3, we just restrict to adjuvant. It's called adjuvant therapy. Coming to T2, that is a stage 2, sorry. Yes, if the risk are high risk factors, high-grade tumors, bigger tumors, spill-off tumors, yes, radiation in the tumor bed and the nodal sites, plus and minus TKIs, usually stage 2, maybe we will avoid if there is no high risk factors. Stage 1, definitely if the surgeon is very confident that the local scans are showing negative, we may not need any radiation or any TKI, just follow them up and then we will take a call if the disease metastasizes.
Yeah, I think you summarized well. Just to make it simplified and as well as avoid any confusion, there are various guidelines now. We are sort of embarking on sort of putting a role of radiotherapy or sort of using TKIs, as has mentioned, especially in the stage 3 disease. That's acceptable. But in general, in community, I would like to send a message for stage 1 and 2. Usually, you are fine. They need to be closely observed, and then subsequently, sort of we take it as the time goes by. But certainly, this is sort of interesting domain where people are talking about radiotherapy as well as sort of adjuvant immunotherapy in stage 3 disease, and that we'll discuss in due course of time. Next slide, please. What about stage 4 kidney cancer? Now, friends, stage 4 kidney cancer, like in any cancer, would be a cancer which would have gone out of kidney and domain of the kidney and would have spread locally as well as sort of it have gone to the lungs and brain and bones. That we call as a stage 4 disease. Next slide, please. Now, this is a typical case of a young man who has a tumor or the growth or a cancer in the right kidney. Next slide, please. Next slide. And typically this was an old X-ray which will show sort of, a big lesion in both the lungs as well as in the right side. Next slide, please. And this is, next slide, please. And this is confirmed on a CT scan. These are the lung lesions as such. Next slide. Now, many times people come to us and people would say, doctor, I understand a stage 4 disease, but, we have been told that get the kidney out. Next slide, please. Get the kidney out, and then we'll deal about your sort of metastasis in the lungs and brain, whatever it is. Now, I'm going to get sort of, the surgeons as well as Dr. Anita on the board for a discussion like this. And I would like to sort of, take you through sort of, the work, what we've done, whether there is a really role of doing cytoreductive surgery in a stage 4 disease, meaning really we need to remove the primary in terms of renal cell carcinoma. Next slide, please. Now, there were a lot of drugs which were available in the past. And as Dr. Anita has mentioned, now we are talking about targeted therapy. And there are many drugs and many trials are coming up. For sort of, community, I think you just have to understand there are a lot of recent advances and a lot of new drugs are coming. They are not chemotherapy, but they are something called as a immunotherapy. Next slide, please. Now, Dr. Anita, do you think the days where we're talking about interferon, interleukin, we really sort of didn't have good response rate? We had some 20% response at CR or complete response for interleukin. Now, a lot of drugs have come now, TKIs, mTOR inhibitors, and are we talking about Pembro and other combinations? Now, what's your take on? Have you really made a progress in last 2 decades?
Yes, definitely. As far as renal cell carcinoma is concerned, we have made a progress both in surgery, diagnosis, molecular profiling of these tumors, as well as treatment. Treatment, definitely, as a medical oncologist, all this. We do the MSKCC risk stratification of these tumors, and then we take, if it is high risk, we give the best to the patient, IO plus pembrolizumab, avelumab, axitinib. These are the drug of choice. Intermediate risk, yes, you can give lenvatinib, everolimus. Low risk, still sunitinib, pazopanib holds good. So risk stratification, targeted drugs, it's the therapy to take these metastatic renal cell cancers forward. But answering in one sentence, yes, we have come a long way with immunotherapy, TKIs, molecular profiling, better surgery, and radiation also with the robotic surgeries and the IMRTs, IGRTs, and the rapid art. Yes, we have.
Next slide, please. Now, these are drugs what Dr. Anita has mentioned, and now we are talking about whether we have a combination of sort of, TKIs and immunotherapy and see whether there is significant survival advantage. I'm sure there is. Next slide, please. And next slide, please. Now, I'm going to talk to Dr. Nagarkar as well as Dr. Prashant and Anita here. Now, we talked about almost last about 35 minutes on renal cell carcinoma. We talked about the stage 1 disease. We know these people have excellent survival rate of something like 80 to 85%. Now, what has made the difference is basically we understand it well, the biology. We now do nephron sparing surgery. We have sort of new techniques. So I think if you ask me what we've done in the last 5 to 10 years is a sort of good job done for a stage 1 disease. Stage 2, also 70 to 75% 5-year survival rate. Stage 3, what we talked about thrombus, I think is more or less same. And here now, I'm sure you all agree, previously, it used to have sort of a dismal sort of outcome for a stage 4 disease. But now with the advent of these, TKIs and immunotherapy, the survival rate is much, much better. Dr. Nagarkar, there are a lot of people who would come out and say, we have met the medical oncologist. We have been advised that we need to have sort of combination of these drugs, either TKIs or Pembro. We want to see the response and then we'll come to you for a surgery. Do you agree, or do you want to get these patients their kidney out and then subsequently send them for adjuvant therapy in a metastatic disease?
In fact, metastatic disease, kidney tumors or renal cell carcinomas is one such cancer where even in metastatic scenario, the surgeon does have a role. But the cytoreductive surgery, somehow it should not be like only where a patient has got a renal mass with studied lung metastasis on both the sides, and then you still go ahead and remove the kidney and send for chemotherapy or immunotherapy. It doesn't make any sense. Surgery should be done if in particular in our organization, our institution, we do it for oligometastatic disease. So if you have a kidney tumor along with 2 or 3 lung lesions only on one side of the lung, go ahead, operate the kidney and remove that part of the lung in the same setting. If there is a brain tumor, a single site of metastasis in the brain, along with the kidney tumor, you operate on the brain and the kidney in the same setting. But if the metastatic sites are not amenable for surgical resection, then we should not operate on the kidney, or operate on the kidney only and only if suppose the patient is having severe bleeding, he's got severe hematuria from the kidney side, then that would be one indication to operate on the kidney. Otherwise, removal of the kidney and keeping multiple metastatic sites back does not make sense in the current era, mainly when we have so many other options available. It is not only about TKIs, even immunotherapy, it's not about single drug, it's a doublets now, they are being tried, and they have definitely shown phenomenal response rates are there.
Yeah, I think it's important when to choose, what to do, and what to offer. It's not worth doing an incomplete job. I think it should be a meaningful job. The next slide, please. Now, just last few slides I'm going to talk to you about. I think we'll skip this. Do we know what causes kidney cancer and the ways of prevention? Because, we know smoking, tobacco, the industrial carcinogens, genetic sort of, causes are there for developing the kidney cancer. The next slide, please. Now, many times we do get, next slide, please, another cancer in the kidney, in the draining system of the kidney, which called as the renal pelvis and ureter. And the treatment is basically, it's not only the kidney, but you have to take the entire part of that sort of a drainage pipe called as ureter and a part of a bladder. And this is also another type of a kidney cancer. The next slide, please. And like sort of, previous sort of, rate transferring surgery, nowadays we are trying to do something like, conservative surgery for these kind of patients. The next one. This is another case where we can do a conservative surgery. The next slide. So it's not that it's very bad to start with, what we thought in the past, but these cancers also can be treated with conservative line of treatment. The next slide. And I'm sure Dr. Anita would also agree, with the advent of chemotherapy, these cancers also do very well. These are not exactly kidney cancers, but what we call as a urothelial cancers. Lastly, next slide, please. We do see tumors in the children, kidney cancers. They are called as a Wilms tumor. Next slide. Usually the age ranges between 2 to 5. And you see they present in either big masses or small masses. The next one. Here is also important. The surgeon has to hold his knife in many patients. Many times the temptation is, I can get it out. But I think it should be discussed thoroughly with the medical oncologist and radiation oncologist. These patients do extremely well, sort of, pre-surgery chemotherapy. You don't miss the chance by curing them by just sort of, going, doing an adventure of taking the tumors out and being a hero in these kind of patients. So what usually we do is we give them upfront chemotherapy, downsize, and things operate. Next slide, please. Many times what happens is these tumors can rupture and the patients can have a chemotherapy, which is to be given for a longer period of time. Next slide, please. Now, as they do extremely well in community, I would like to send a message. Childhood kidney cancers have excellent prognosis, but as Dr. Nagarkar has also mentioned a while ago, it's just not the surgery. You need to get the medical oncologists on the board, put them with the chemotherapy and radiotherapy, then and then you can achieve this result, otherwise not. Next slide, please. This is just a child we operated just recently, and when I saw the picture, it looked like a cute picture. But you know what he's looking at me? He just wants to know, what's my future like? What's my other kidneys going to behave like? What's my body growth is going to be like? Whether I'm going to be sort of behaving, going to be future like a good man or sort of a healthy man or not. So when I sort of order a treatment, in terms of surgery, chemotherapy, radiotherapy, I have to titrate the treatment in such a way we have a long-term outcome. The next slide, please. And it's pleasure to see these kind of children, We have a Wilms Tumor Foundation and we have children doing extremely well. This was a child I operated almost 1999, is 2022, is grown very well, almost 23 years, no problems in the body growth and the contralateral kidney. So it's extremely important. So the message I would like to give here on the Kidney Day, World Kidney Day, is we talked about the kidney cancer here. We talked about the kidney cancer stages and what treatments are. We also talked about, what is involved in sort of, care of the cancer in children itself. I really thank Dr. Nalini. I thank Dr. Prashant, Dr. Anita. It was wonderful interacting with you and meeting you online. I'm sure we will meet in person due course of time. Thank you very much. And I think we are done in time as such. Thank you again.
Yeah, thank you so much. We
Thank you, sir.
enjoyed the meeting. Thanks.
Thank you so much, sir. It was a good interest.
Thank you, everyone.